Well, hello everyone. Thank you very much for coming today. I'm delighted to introduce Professor Mads Nielsen from University of Copenhagen. He's also the co-lead of the Pioneer Center for AI, Denmark's National AI Center, as well as at least three, maybe more AI medical startups, including some that motivated this trip. Matt's done a lot of great work, especially in the imaging domain and other areas of health AI, various different domains, Alzheimer's, breast cancer, I think a couple other notable ones. But what I'll share instead is how I met Matt, which is particularly relevant today, as for reason I'll share in a moment, which is I ran into one of his students at the time, Kirill Klein, at a conference, who had done some great modeling work on EHR data. And this was right when we were first developing meds. And I was going around to people saying, "Oh, this looks great. You should put this in this meds data standard for EHR, and then we can." Oh, I should probably be over here so they can hear me better. Sorry, folks on the Zoom, but you should put this in meds, and we can talk, and I'll tell you about how we can set it up, and then other people can test it. And I said this to many people, but Kirill and Maria and Mikkel and others in Mads' group were very enthusiastic about actually making their model more usable by others, externally validatable. And that work has borne a lot of real fruit, and they were major contributors to the MEDS effort, which is especially relevant today because for Mads and Shamli and I and others who are not in this room, but the MEDS paper actually just came out today, coincidentally, co-timed with Mads's talk. So yes, but regardless, very delighted to have him here to tell us about his work on the Danish medical data machine learning. Sorry, Craig, was there something on the Zoom or? No?
No, you're good.
Okay, great. Sorry. So without further ado, thank you very
much. Thank you. And thanks, Matthew, for the introduction and for welcoming me here. It's a pleasure being here. So I've worked with various departments from New York during my career, but it's first time in this building. So it's a pleasure being here. And thanks when I, with a short notice, said Matthew that I would be in town putting this up and so on. It's a great opportunity to be here. So what you see here is our building. So it's one of my few political victories at the University of Copenhagen that we actually managed to move into this building with the Pioneer Center for AI. It's a historical building in the center of town, and I have my office in that building every day. So that's one of the greats. And to the left of that, you see part of my group, those that were present the day we took the photo. So it's approximately half the group. But Kirill, that you mentioned, is here. So, yes. Let me see if it can. Yes. So the Pioneer Center for AI is a national center. So you can see here that there are stickers towards 5 Danish universities. It's coordinated from University of Copenhagen with the headquarters in the building I just showed you. And then we have 5 foundations that are behind it. There's the one that's called Danish National Research Foundation, which is a governmental organization. The others are private foundations. So ever since Carlsberg did his breweries and didn't want his son to inherit it because he made a competitor called Tuborg, he set up a foundation that should support science and arts that owns the company. And then the king said if he was doing it like that, then he would not have to pay taxes from that foundation. And then many other major Danish companies have made the same construct, that their holding company is owned by a foundation. It holds for Novo Nordisk, for Lundbeck, and Willum that are making windows. But it means that basically, I think 80% of my research is supported by independent foundations owning Danish companies. So it's a little particular ecosystem we have in Denmark for that. So to come and head the center, Serge Belongia, that was actually a little down the river from here at Cornell Tech, where he was associate dean, and he moved to Copenhagen in order to head the center when we started it 3 years ago. And is still there and trying to using all his power and energy to shape the Scandinavian ecosystem around academic AI. So disclosures, you also mentioned that I'm involved in a number of startups. I'm going to mention just briefly what they're doing, because this is the real way to get our results out to the patients. It's a long way, but if you want to treat others than some in your local clinic, then you really need to get it regulatory approved and scale it out and send it out to others. And so that's the mission there. I'm involved with breast cancer screening. So our company Bionetic was merged into Transpara, or ScreenPoint Medical, that is having the product Transpara, that is, I think, the market leader in AI for breast cancer screening, and at least the first product that in a massive RCT was proved to have a positive effect both on reading time and on lowering number of interval cancers, increasing the number of small cancers you find, and so on. Cerebro is doing brain MRI while the patient is in the scanner, adapting the protocol to what's wrong with the patient. It's being in an MRI, it's like a chicken and egg problem. You go into the scanner to find a diagnosis. Given you have the diagnosis, you want specific images recorded. So that's trying to not having to make 2 sessions out of that, but doing it in 1 session. If you see the cancer, then you go to a time of flight also, etc. Then IOMIC is doing abstraction across registers, mainly in US, so that you can take your quality data and submit them with less manual work. And then last but not least, Prenatal is our company looking at prenatal ultrasound, trying to find too small to large fetuses, preterm birth, and other pregnancies at risk, basically. And that's based on that we have access to data from 1 million pregnancies, around 50 million images, and the according patient histories for those. So we try to make models that can do these kind of things. So in my group at university, we are doing, you can usually see 1 per company, because that's, of course, we only have spun out companies in areas where we do research. But the one I'm going to talk to you about here today, that is the registers and the electronic healthcare records that we are using, and also together with Matthew on the meds have been doing what we have been doing in that relation, and I'll not talk much about the other stuff, except for I give a brief intro to it. So the brain image analysis, we are running a challenge at MICAI also this year. It's called FOMO 26 then, no surprise, that you can sign up and get access to this. We have harvested from the internet 300,000 brain MRIs that are in various data sets that are under license, where you can share them again, reshare them. So you can just go to Hugging Face and with 1 click download these 300,000 and participate in the foundation model challenge there. So in the fetal ultrasound, we have made a foundation model based on all these images, and the numbers I'm sharing here to the right is saying that this is just for first trimester screening, trying to find Down syndrome, and that we find them all, but we also find in the Danish screening program, but it also comes with a cost of how many biopsies do you do. And of course, so those that are where you actually take the biopsies there, the Nicolaides risk model that we are basing it on has an AUC of 84. Then if we were just doing a ResNet-like structure and putting in the clinical data as slate fusion, it was 89. But if we're using the foundation model and do what we call early fusion, where you tokenize the clinical information and put into the foundation model. So you can see it's a shift of paradigm. We've always been used to doing medical image analysis, where we do it in the context of the image, and then later on we add on the clinical information to improve. But the radiologist would always do it the other way around: look at the referral, take the context of the patient, and then look at the image. And it's, at least for this application, we see a couple of other applications, that this early fusion, where the image analysis made in the vision transformer has access to the clinical information, actually improves the image analysis. So that's one of the things I see is promising across all our applications. Then we are doing, that's Svetlana in the red jacket there to the right. She's a PI on projects where we are taking more deep genomics, proteomics, metabolomics, and also what she calls exposomics. So from mass spectroscopy, you get a spectrum of the chemicals that you see in a sample, and then you can take it from drinking water, from air, and so on, and then see what people have been exposed to. And then the breast cancer, as I mentioned, where we have been doing this, also really implementing it in the screening programs, and are doing also a risk model for the risk of future breast cancer. It is solely based on images and age and two other numbers right now, but we are working on getting all the electronic healthcare register data into these models also. And we are together with ScreenPoint trying to get it FDA approved, etc. So that was the introduction, long introduction. Danish data. So in 1968, it was agreed that we all have a social security number in Denmark. That is the birth date plus a serial number. And then ever since, whenever we do anything, go to the doctor, get social services, whatever, it is based on that number. So we have a unique key that links everybody in all what they do. So we have in the order of magnitude 10 to the power of 7 persons, and when we 10 to the power of 8 person years in these registers, and 10 to the power of 11, nearly 10 to the power of 12 records on these people, healthcare records on these people. So that's the basis. So here you can see the history of data collection in Denmark, where in 1970 we had the cause of death register, then we had a pregnancy register in 1977, and so on, more and more registers being built all the time. So we have kind of a 2-layer system. These are the national registers that you, by law, have to submit your data to if you're a medical professional. Then we have quality registers that are governed by an association called RKKP, so there's some Danish abbreviation. But they are much deeper on specific specialities. And for example, in the fetal ultrasound, we also have the fetal database, where you would have all biometries taken out from the ultrasound images and so on, is also part of that database, not the images themselves. If you look at it from a person perspective, then you are basically covered from birth to grave in the registers, what's coming in. And we do have in our healthcare law a paragraph stating that researchers can get access to this data if it's for a societal purpose. So we have to go through a ethical approval at a national body, and then if we get that approval, then we can get access to the slice of the data that we want to have access to. So, yes.
Stop speaking before I start the question. Sorry. I'm just curious. What happens with startups? Like, can they also require access to this data?
So in principle, there's nothing against it in the law, because it's just if you do something for societal purpose. So if your startup has a something that is societal, then you can get access to them. Normally, startups will get access only through hospital collaborations. So that there's a professor at the hospital that has access and then get allowed to share data with the company also. So it's a little, you can say, favoring professors that want to make startups in that system, because it's very difficult to come from, in practice, to come from the outside and just gain access. You can try, and then I don't know what would happen, because normally it goes the other way around, that you have a research collaboration with the university and so on. So that's the way. So these are all in Danish, but these are some of the registers, and these are registers that we have access to in our projects. So you can, the most important is the Landspatientregister that have all diagnoses and medications and you can say major treatments, those that you must report to the registers are in there. But also the sygesikringsregister, because that is all, you can say that's a claims database basically for all the general practitioners and private practitioners in the country, that all their actions and the patients, all the things that they claim for will be in there. And then we have the so there's a register on drugs also, where you can see not just that you got a referral or for a drug, but also that you picked it up in the pharmacy and so on. So that's a little more compliance data in that way on these things. So this is what we are working with in my group. It's under so let me just go to imaging. I couldn't find a newer statistics than one that is 12 years old of the number of images that are produced in Denmark. They're making such quality reports, but they stopped doing the statistics after 14 on or at least showing it to me how many images of various types that are taken. These images are not in registers. So if we want to work with the images, we have to, we are 5 now changing into 4 regions in Denmark. You have to go to the individual regions and get an agreement with them to get the images from the PACS. That's what we have been through with the fetal ultrasound. For brain imaging, we are only working with the images from the capital region, because it's simply a lot of work to get out and getting the images from the other regions. Hospital data, under the same law, we can get access to production data in the hospitals. So it's a little deeper, even though they're quite detailed, the registers. There's of course a limit to what's reported to the registers. Here you can see the epic from the capital region of Denmark, our eastern region, because it's also Region Zealand, and they're being merged now, and they have the same IT system. That's lucky for them. So you can see, for example, we have 2,000 unique medicine codes used in the system, and 140 of these were used less than 10 times over this 10-year period. So either it must be a very expensive drug, or it's a bad deal for the pharmaceutical company producing that one. But what you see also with diagnosis, lab tests, procedures, that basically a third of them is used very, very rarely. So it is dominated by a few type of events that you can see here that are used very, very often, and then a very long tail of strange events that happen rarely. So that's, and I normally say that this is the reason why we need to do machine learning and not standard epidemiology, because it's simply all the work is in categorizing the data before you do the analysis if you're doing that. So let's the reason why I went into this, I'm originally from medical image analysis, was the COVID, and we normally it takes 2 years, 3 years to get access to data and all the bodies and so on. Here we had the Minister of Research, the Prime Minister. She announced the close down of the Society of March 11, 2020. On March 12th, we were online teaching in our department at 8 a.m. the next morning. There were a few professors that were really saying, we just have to do this. And then they, because they were computer scientists, managed to do that in a notice of 11 hours. But then we were set in, so we were opening and closing the society based on how many ventilators do we have in Denmark. We would never get to the point where we would not have sufficiently many ventilators. Then we need to close down society a little more before we got to that point. So that was why we so we were actually on a bank holiday granted access to the data by the head of the region that was working on this bank holiday in the Easter. We got access to data and could then, in these days, we were then doing this kind of work with XGBoost because it was just about doing things fast that was sufficiently good. But it got me and others to think, how would we actually do this if we were to do it in a proper machine learning fashion, looking at these health sequences for all these patients? And that's why we started the work on BERT and so on. I'll just jump this one. That is the poster presentation at the LM for HC where we met Matthew when Kjell was presenting this. So I'll just go a little through what we were doing in this paper. So we have these time series of events for the patients. We put them into this input sequence. Then we add the age, the position of where we are. So this is based on hospital visits, so we can add the visit number, and then we put add all these things together and make a linear embedding, and that's that is the tokenization of the events, and then we have these tokens that we can then run our transformer models on. So that's the simple system for doing that. And then we create the embeddings, and I'm going to show you a little more modern versions of them here. You can see here are the ages of the patients. But if you especially look at this island up here, that's the pregnant women. They are different in the embeddings than anybody else. So that's what we are working with, creating these embeddings and fine-tuning them for specific purposes. What Kjell and Mikkel did in this paper was to go through all these design choices that you're always in doubt of, and some have reported this, some have reported that, and trying to do a quite thorough evaluation of which elements to include, and then saying that, for example, separator tokens didn't improve on performance, so we leave them out, and so on, trying to tell a story about how to put together such a machinery so that it's robust over a number of tasks. And then we tested it on, I think, 32 different tasks of prediction of healthcare outcomes. Here are some of them where you can see, for example, predicting breast cancer has an AUC of 0.64. If you go into standard models like the Thai-Cusick models and so on, they're normally reported to have an AUC of 0.6. So it's better than the standard risk models that take family history and so on into account. The modern models that also use images and machine learning on top of that goes to 0.7 or something like that. We are just scraping the surface of trying to combine the two to do that. The other thing is the preterm birth. So that's the first sign, so it's censored at the first sign of pregnancy in the health records, and so you can say the day of conception. So we're not taking any of the measurements during pregnancy into account, and we have an AUC also of 0.64. It's not impressive, but if you look at what you actually get out of the cervix length when you measure it, it is 0.67. So it is the same order of magnitude looking at the medical history of the mother. Of course, a lot is driven by age and earlier preterm birth, but it's not taking into account here multiplicity of the pregnancy because they don't have access to that. They just know that the woman is pregnant. So that's and that we can of course also put in and make it a little better than the 0.67 to do it with 0.75 in a machine learning, and that's what we have improved even further and tried to combine these and so on. This is ongoing research about how to get as much information out of cervix images as possible. And we are next year starting an RCT with all women in the eastern region of Denmark, where they will be offered a transvaginal ultrasound screen at the normal second trimester visit, looking at the cervix, and then we are trying. It should be powered so we can see also the downstream treatment effect of treating these women that are found high risk in that, compared to if we are just using cervix length as the measurement. Yeah.
Did you ever look to do any analysis to what extent the signal in the cervix length less than 25 millimeters versus the maternal EHR record? Like, are those signals complementary? Is there some combination that's sort of stronger than the whole? Or?
We don't know. So what we can see is that it's a mixture of the two, that they are both saying the same thing, but there's also additional information in the electronic healthcare registers. So far, we have not put the full embedding model and so on, tokenized that and put into the models, but we have only taken what we know is relevant information. And one of the signals that came out, a very important thing, is whether the mother has ever had chlamydia. So that is obviously a risk of preterm birth. Also, if she's not vaccinated against HPV, because the papillovirus also increases, or maybe not the papillovirus, but if you have had your screening and getting this cone, whatever it's called in English, kejsersnit in Danish, then that's a risk of preterm birth. So yeah.
There was a mention of social determinants of health.
Yeah.
Is that included in the classifier?
No, because this is only healthcare data. So we don't we could apply to get access to the social data also. What we have seen in other studies where we were looking at the risk of cancer and stroke and these things, is that actually the healthcare data shadow the social data. Thereby, I'm not saying that the social data is not important. What I'm saying is that you see trace of the social data in the healthcare data that yeah. So that's yeah. So that's yeah. So the reason why we got access to all this data is to look at side effects of drugs. So you all know this, that you have the clinical trials pre-approval, and then post-approval, many others start using the drugs that were those that were in the inclusion criteria of the trial. They have comorbidities. They may be older, younger, may even be pregnant, and so on. So that's why we cannot just rely on what is in the labeling of the drugs. Actually, also a lot of the labeling have side effects that are not real. They were just found a few cases in the clinical trial, and then the agencies have asked them to label it with a side effect of so ibuprofen that many of us takes once in a while. It has a not rare event of a bleeding from the stomach. If you look at the labeling, I have never had that, and so there are both side effects that are not there and side effects that are overemphasized in the current labeling. And we have this system with the spontaneous reporting that came after the thalidomide crisis back in the 60s, but only around 1 per mil to 1% of the actual drug effects, even though there's a law saying every healthcare professional must do this. There are several reasons why it's underreported. One thing is that it's work, so it takes time away from the patient. Another reason is that if it's not a hitherto reported side effect, how should the doctor know that this was a side effect of the drug? So there's also this that you don't have the full picture as the individual clinician when you're doing that. And that actually makes it nearly impossible to find new side effects because you need the doctors to make the connection themselves of that this could be a side effect of that drug, and they see only a few cases each of them. So that's so this is the whole system. I don't want to go too much into that. The idea is, of course, that can we look at the data, apply our AI, and come up with the treatment effect estimates of side effects? Can we find those based on the data I've just told you about? So what we did was to put up this secure HPC facility physically at the National Genome Center, where we bought some GPUs, and we can put the data there and then get the data in there. And I already showed you this, that we can do this kind of modeling where we can find the risk of events. So here is from another study where we are looking at adverse events after surgery. You can see the embedding as it looked like in the pre-trained model and then in the fine-tuned model. And here it's colored by age. So you can see basically we know that adverse event after surgery is very related to age. So it basically takes everybody and put them into a snake that's folded into this embedding space. And you can see the black dots are those that die within 30 days after surgery while they're still in hospital. So that's, but that, I wanted to show this because I was amazed about how much the fine-tuning is actually doing here. That you take something which is, they're put out, once again, we have an island up here of the pregnant women, but how much and how important the fine-tuning is. So if we want to do this with side effects of drugs, we need to go into causal inference. So we want to have not just getting to know that those that take the drug, they are ill, but that because they take the drug, they get new events happening to them. And there, the essential thing, no matter whether we go in classical propensity weighing in our studies or we go to the more modern targeted maximum likelihood estimation, then the two key numbers to compute is the probability of exposure and the probability of outcome giving these exposure. The IPV only uses the first, the targeted learning also the second number, but this is the key, and then we can put it into all our formulas for causal effect size estimation afterwards if we can compute these numbers. So if we just look at the causal diagram, we have the intervention here in the middle, and there can be a lot of stuff happening here. We have the confounders, those that relate both to treatment and outcome. We, of course, have to adjust for those. Then we have so-called precision variables that relate only to outcome, the instruments that relate only to the treatment, some variables that relate to nothing, but are just there in our electronic healthcare record, and then the so-called mediators. The whole thing is that if you go to epidemiology, they will always say you must only adjust for the confounders. You should never adjust for the instruments because you're removing the strength in your signal. My claim is that if we are using the machine learning methods in a sensible fashion, then we should just adjust for everything that comes before the event of the treatment. You may remove some of the signal. You don't get any bias for having instrument or precision variables in there. You get a little more noise in your estimates in the end, but then you have conservative effect estimates. And the reason why I'm interested in conservative effect estimates is that we're going to do screening. We want to take one drug and 1,000 side effects. So we don't want to. So it's okay that we have a little too much uncertainty. We don't want to be biased, but maybe we have more uncertainty in our estimates than necessary. But we can find those that are significant are conservatively significant then. So that's what we do. We take all the events that are before and call them potential confounders, and then we just put it into the core BERT. We will have unobserved variables if they are only related to intervention. It's no problem. If they're only related to outcome, no problem. Of course, if there are real confounders that are unobserved and there are no trace of them in data, then we do have a problem and we'll have bias in our effect estimate. This is something we can never get around in causal effect estimation. Here, we just have to look at how sensitive are we to such events. Yeah.
Does the scope of the Danish registry data give you, have you considered leveraging the breadth of variables and data types available to try and mitigate this risk further than might be possible in settings where you have more limited features, right? Because you can observe more of the possible confounders.
So if you're thinking of social data, yeah. So I do believe that we have a lot of traces of the social data, as I mentioned before. So we haven't gone that way, but we could do it. But so far, we have only been working with the healthcare data there, but not the social data. So yeah, we should try one time to look at when we clean it for the healthcare data and whether the social data can still leverage analysis in any way. Yeah. So these are just the formulas for how to do the effect estimation. So they're standard formula from when you know the probabilities, and you can do either the IPW, so inverse propensity weighing, or the targeted machine learning. The essential thing is that you are taking the treated and the untreated, and then you're weighing the untreated in a way so that they resemble the treated in the end, so that it is for the patients you're looking at, it's random whether they got the treatment or not. That's the philosophy between this. So we can take a well-known trial, Ozempic trial, SUSTAIN 6 trial, and that's saying that Ozempic reduces the risk of cardiovascular events. And then we could run it through that machinery. Here we know what the RCT was saying. And here you see that basically we got the same effect estimates by that, except that we had a big effect also on all-cause death that we did not see in the trial. That is potentially because even though we tried to use exactly the same inclusion-exclusion criteria, they are not as healthy as they were in the trial because they had been selected for the trials. So funny thing is, when we just had these numbers out of the printer, breakthrough paper came in Nature Medicine from Boston, where they also showed the same thing, that the all-cause mortality was reducing on real-world data in Boston. So it's coincidence on these things. So the next thing we could go through, now we're looking at the 2 million people in the eastern Denmark, all those that got semaglutide there, either Ozempic or Wegovy, and looking at the effects of that. So we can do all that stuff. In order to make sure that the embeddings we are looking at can actually adjust for the confounders, we are making a head for all of the possible outputs we want to look at, so that the embedding is not just capable of predicting the treatment, but also that it can predict the effect on all the downstream tasks that we want to look at. And we could actually show that that in synthetic data, that by doing that, we are removing bias if we are putting just a little weight to these. And then, of course, if we give them more weight in the embedding, then we introduce bias in that way. So that's what we did. And then we did it. And here's volcano plot, where you can see for all 2-year window of whether you would get medication, other types of medication, if you have been starting taking semaglutide. And you can, for example, see here that you have a very reduced risk of getting other diabetes treatment. That is because you're getting this instead of that. So that's just a sanity check. And then we can look that you get less osteoporosis treatment. You get less for nicotine dependency. So these are all stories that we have taken for other people have published that there may be a relation. We also have eye antibiotics because it's known, I can't remember what the disease that you can get in the eye from, or maybe can get from GLP-1 antagonist. I think it's, but it's not treated with antibiotics. But you go to the doctor, have problems with your eyes. The first attempt is, okay, we give you antibiotics. So that's my interpretation of these data here. And that also takes me to this, that it's very, very difficult to interpret these data. That can be the effect of semaglutide directly. Another effect can be that when you're on semaglutide, you go more to the doctor, and the only way to get prescription drugs is by going to the doctor. So you will have more prescription drugs when you go to the doctor. It can also be mediated by weight loss, so that changes behavior of the individual. So we can see more treatment against erectile dysfunction in those that's on semaglutide. So since that's mainly a cardiovascular thing, and it's positive with cardiovascular, we think that it's mediated through the weight loss that and so on. And then there's this other diagnosis or treatment up here, where you see that I say baseline illness, that is what we ought to adjust for, but we do have unknown confounders, the system is not perfect and so on. So there can also be, so this, you can also see wrong adjustment would go through this channel. So whenever we interpret the data, and what I've asked our pharmacovigilance people doing is saying, before they analyze any of the drugs, they should put them into these boxes before they see the result, so that we can interpret the result. So otherwise it becomes like a horoscope. You see an effect and then you read it into, oh, that must be because of this. So but it comes to when we have results like that, where we have hundreds of significant events, the next problem is actually how do we analyze this data? Because we could produce these data overnight for any treatment. So that becomes how do we actually analyze the data and get and think that we have evidence now and not just a hypothesis. Surgical complication, I showed you the embeddings before. So we are doing out of time evaluation on this. And I showed you This here it's colored by age now. It can also be colored by gender. You see the pregnant women up here again, and all those with the mortality. So basically it becomes, here's a chronic diseases in the embeddings here, and they are towards the outer side of this snake here, so that when you have the same age, you fall to more chronic diseases. So this is, of course, just a two-dimensional visualization of 718 dimensions. And traditional risk factors for adverse, so that are coming into these frailty scores are shown here. So that shows that, and we can get fine AUCs predicting who will much better than the didn't show the usual risk factors, your normal risk measurements, but they are around 7.5, 7.8 or in their AUCs, and we get up in the 90s here with these for mortality, for bleed, for acute renal failure. A little more noisy here because there are so few of them, luckily, and respiratory insufficiency here also. For getting these, our labels are not perfect. So we actually know for something like wound infection after surgery, it is coded with the right diagnosis code in around 7, not 70 or 17, but 7% of the cases. So we have made a machine learning on the nodes in order to try to recover the label. So we had med students going through the whole production of 1 month in the region of all surgeries, seeing would they have wound infection or not, would they have other conditions, categorizing them. So we had some training material to try to use for the others. And for some of them, wound infection, we can do that nearly perfectly because there's both trace in the changing the antibiotic, prophylactic antibiotics people get and so on. But some of the others, we are still uncertain. We can't do it perfectly. So last thing, I'm just going to, because we're getting towards the end. So that's Maria that also worked with Matthew, that are very happy that a paper just got accepted for ICML on how to code the lab values, basically, in this. So the major work of this here was not a new way of doing it. It was taking well-known methods from literature, just like in the BERT strategy, and trying them out. But trying them out where we know the ground truth. So she did a lot of simulations. She injected in real patient sequences new signals, artificial lab tests, where she know how they should relate to the outcome that she also injected artificially herself. And I'm not going for the sake of time over that are differences in these. There's a scaling law if you try to bin them discretely, depending on how many you have, how many bins should you make in your histogram. Here are some, so I just wanted to say this information efficiency that we're using all the way through, because it's an artificial signal, we know what the AUC could be, and we are then looking at about how far from 0.5 up to what you could get are you actually getting. So information efficiency 1 is if you get to the theoretical bound of how good this can be done, and 0 is if you get no information whatsoever out of these biomarkers. And then you can see here, this is an addition experiment where the outcome is determined on the sum of a number of numbers that come in events at random time points in the history. And you can see up to 100, 150 labs, some of the methods can do this perfectly. Even though it's well known that transformers cannot do exact calculus, this kind of rough calculus, figuring out am I above or below the median of all these, it can do nearly perfectly, even for 100 numbers. when we add noise, things degrade as they should, basically. And then a lot of experiments. There's also multiplication. There's a polynomial task where we make a 5-order polynomial out of various numbers, and then we threshold the value of that polynomial, and then categorize patients according to that. And that transformers can also do. So they can do quite complex. One of the things that they had a hard time doing, except from the film embedding, was if you have a value that you have a Gaussian noise around that, and then you have a jump to a different value, but you don't know any of these two values for the individual patient. It's just the fact that there's a jump, and that we thought was a challenging but realistic situation where you would have an individual number and then something changes. And that it actually had a hard time identifying that whether a jump had happened or not. And in general, you can see that the film embeddings, they are in most cases, so this is a rank of how good they are, and that's more often ranking higher than the other methods are. But they are also a little challenging because you have to change your encoder the whole way you do your encoding. So it depends a little on whether you want to be interoperable, and then binning is fine for most cases, but the film embedding is a little better, especially when we get to the low data regimes and so on. They're better. So that's the conclusion on the paper, and that's I think also the conclusion of my talk. So we have taken all the registers we have access to, which are nearly all the Danish registers, and made them into pre-meds format and so on. So we can run, if people come with algorithms in meds format, we can run them. Of course, we need to have the ethical approval in place for whatever we are doing on the data. So if it falls under one of our ethical approvals, we can do it right away. It, of course, also comes with that I'm not the holder of the ethical approval. That's always the medical doctor. So it comes with obligations of co-authorships and these kind of things when we do these collaborations. But that's just how the ecosystem works. So and that last part, that was an invitation to collaboration.
Well, thank you very much. We do have time for questions, so if folks have any questions, please feel free to chime in.
I was curious about the causal effect estimation part, because you're tokenizing the history, and then you have treatment, which is like a very small fraction of tokens, and then there's the outcome. So I'm just trying to understand
So we are centering the patients at the time of treatment, and then we are taking the untreated and draw the time of non-treatment from the same distribution of times as the treated were, and then we put in a token there saying untreated. That's how we are doing it in practice, because we need to censor the untreated in the same way as we censor the treated, in order to not to have any kind of censoring bias.
Thank you so much. Fascinating talk, and it's interesting what's possible when you have central
Yeah.
which think we can from a distance appreciate the beauty of it. So, but you talked about this kind of structures for accessing data. Can you talk a little bit the other side of it? If there are interventions built on top of it, how do you deploy those into practice? What are some of the ethical regulations?
Yeah.
How hard is it?
Yeah, so whenever we are taking out general knowledge, like the side effects of drugs and so on, they can go immediately into guidelines if the appropriate committee finds that useful. But if we go to the individual level, and it should influence treatment of the individual. Then we are under the medical device regulation. Even though, so the medical device regulation is nasty because it's not just taking about marketing thing, it's also taking about using or putting them into use. So that means that even the things we make locally in our own clinic, we will have to go under a lightweight version of the MDR in order to use the models. And then you're getting into the gray zone about how lightweight should that be, and the university hospital doesn't have an ISO certification in place and so on. So how do we actually qualify that it's? We have models up and running that are being used for guiding treatment of patients. Carsten Niemann has been doing for leukemia patients he's putting the dose up and down compared to how the immune system reacts, basically. And then he's making this risk of immune reactions, and then he's changing the dose on a daily basis. So, but these are the very rare cases because it takes somebody that are persistent and stubborn and so on in order to get it through the system. There's the legal system, then there's the IT system. The IT system, after they made the first models and saw it was a success, they're a little easier to work with now. But yeah, so the actual way to do it, if you want to do it, is to spin it out into a company, having the ISO certification, do regulatory approval, and then you can use it. That's it is terrible. It's much too hard. That's the one thing. Getting the ethical approvals are also difficult. They always want you to minimize how much data you get access to, and machine learners are data hungry. So we get into debates about these things, whether they are, and we work a lot with the organization Danish Patients, because patients are actually interested in that we get access to data. So they are talking our case. So that's an important part of it all, that patient trust the data to the system, then the system should be trustworthy. And that's why we work both in the fetal ultrasound project and in this side effects of drug. They are project partners in the projects and make workshops with patients that make guidance of what we should look into. Yeah.
I had a very similar question. I was like, what are you doing? My question was more about something like the surgical infections. Like, how do you operationalize that data into something usable by clinician?
Yeah, so these models were made on the EPIC data. So there we have the data available in the system. So the way is actually that it can run every second hour. There's a clarity dump from the EPIC. It runs in the clarity dump and so on. So that can be automated. So that you with a 2-hour delay, 3-hour delay, can get a risk score for the individual patient. And normally you would do that in between you plan surgery and you do the surgery.
Oh, you can just pre-op.
Yeah, so we center them at the time of operation, only on what was planned for the operation, not what actually happened during surgery, and then we do the risk modeling based on that.
And is that happening now?
No, that's not happening now. We are hopefully soon publishing it, but that's then it takes yeah.
Right, wow, interesting.
Yeah.
You're doing it that early on in the process, that it's pre-op.
Yeah. So it is in order to guide around frail patients. It's the dilemma of all the surgeons. Should I do this hip? Should I not do this hip? Either the woman can't walk the rest of her life, which will be very short, or maybe I kill her with my knife. That's yeah. So that's what they're really interested in, getting some kind of objective measurements. So they also for their consciousness. So saying we actually took all information into account, and it was not me making the call in the end. Of course, it's them making the call, but they had some evidence.
Yeah, because I've seen prediction models for infections post-op.
Yeah.
But I don't know how useful that is. It's not going to change my management.
No, so yeah.